Hello, and today we're going to be talking about first-generation antipsychotic drugs, primarily the phenothiazines, but there are some newer drugs that we'll talk about as well, relatively newer. Um, but first I want to talk a little bit about this class of drugs and what they include. I'm not going to give you a comprehensive list. You can see your textbook for a more comprehensive list. Talk about the three that are the most commonly used, or at least the ones that I am the most familiar with, and given my level of experience, I'd say they're probably the most commonly used. So this is the first generation of antipsychotics. We talked briefly about how these were discovered previously. These first generation of antipsychotics include drugs like chlorpromazine, which is thorazine, prochlorperazine, which is compazine, and thioridazine, which is meluril. Historically, these were the most widely used for treating schizophrenia up until the probably 1970s, 1980s. While they are primarily used for the treatment of schizophrenia and psychosis, they are also used to treat for nausea, sedation, for sedation, and to treat premature ejaculation. Compazine is primarily used, or was primarily used, to treat nausea. We have better drugs now, but compazine has been used for that in the past. Talk a little bit about the pharmacokinetics of phenothiazines. They tend to be absorbed very erratically from the GI tract. However, over long periods of time, you do get stable plasma concentrations. Most people who are on these drugs are going to be on them for a very long time, and so it might take a while to reach that stable plasma concentration. But once you've reached that, they function fairly well. Intramuscular injection does increase the efficacy of these drugs. Obviously, that requires usually a nurse to provide those injections. There's obviously a cost associated with that, but it does increase the efficacy of these 4 to 10 times. So oftentimes what you'll see is in an inpatient setting, they'll start off with an IM injection to get patients up to functioning very quickly, and then transition to oral preparations. Important to understand that levels of these drugs are much lower in the brain than other tissues, and of course what that means is there is great potential for significant side effects in those peripheral tissues. So we have to get a lot of drug in the body to get a little into the brain to get it to affect those treatments. The half-lives of these drugs are from 24 to 48 hours, and so that's a pretty good dosing regimen. You can give patients a pill once a day or twice a day to try to get to that level that you're after. And so it's a relatively easy dosing regimen. It doesn't require multiple times a day. So just as a review, how long would it take to reach steady state concentration? So look back into pharmacokinetics and think about how long it might take to reach steady state concentrations of this kind of drug. So what are the pharmacological effects of phenothiazines? Well, they block the D2 receptors, which is again a type of dopamine receptor. They also block acetylcholine, that is, they are anticholinergic. We refer to drugs that block acetylcholine receptors, which of course include muscarinic and nicotinic receptors, as anticholinergic. These tend to block the muscarinic receptors most. In fact, most antipsychotics block the muscarinic receptors. These drugs block D2 receptors, acetylcholine, histamine, and norepinephrine. The cholinergic blockade has some significant causes some significant side effects. Remember, acetylcholine is particularly important for our peripheral nervous system and functioning, things like muscle functioning, that sort of thing. So the side effects tend to include things like dry mouth, dilated pupils, blurred vision, cognitive impairments, constipation, and tachycardia, which is, of course, elevated heart rate. The noradrenergic blockade causes hypotension, which is lower blood pressure, and, of course, sedation. Tends to make people sleepy. So these aren't perfect drugs, and they're not used as much anymore because we do have much better drugs. Now, sometimes patients won't respond to those newer drugs, and so the older drugs are still prescribed to some of those people. Now, to talk about the brain systems affected by phenothiazines, there are a variety of brain systems affected, and each of these causes different issues and problems. So we'll talk first about the brainstem. Brainstem is involved, of course, in regulating our internal environment. Behavioral arousal and vomiting tend to be what happens or where this drug has its effect. So it's going to reduce arousal and also, of course, reduce nausea and vomiting, which is why compazine is oftentimes used to treat nausea. Unfortunately, it also produces an indifference to external stimuli, which obviously is not something you probably want. If somebody's going to be engaging in their environment, if they're going to be out functioning safely, they're going to need to pay attention to external stimuli. The hypothalamus and pituitary are also affected by these drugs, which causes a change in appetite, decreased sexual arousal, and hormonal disruptions. The basal ganglia, which we talked about in previous lectures, are primarily involved in coordinating our motor functionings, and the most severe side effects here are produced by alterations in basal ganglia functioning, and so this tends to be where we get things like extrapyramidal symptoms and tardive dyskinesia. So the basal ganglia, which are incredibly important brain structures involved in motor coordination, tend to be very, very affected by these kinds of drugs. So I want to talk a little bit more about some of these symptoms caused by the basal ganglia, and the disruption of dopamine, particularly in the basal ganglia. And one of the most significant of these is what we call acute extrapyramidal reactions. And these include akathisia, which is anxiety, constant pacing, rocking back and forth, repetitive purposeless actions. This tends to be very problematic for patients, and in fact it's one of the significant reasons for a failure to use these drugs, that is drug compliance issues, and so this is a significant side effect. Dystonia is another really problematic side effect because it makes social functioning for these patients very difficult. What happens is you get involuntary muscle contractions and sustained abnormal and bizarre postures, including the face, tongue, trunk, and limbs. And then finally, pseudo-Parkinsonism. And what this essentially does is it resembles Parkinson's disease, which is why it's called pseudo-Parkinsonism. There is a schizophrenia-Parkinson's connection through dopamine. Give Parkinson's patients too much L-Dopa, they get schizophrenia symptoms. Give a schizophrenia patient an antipsychotic and they develop pseudo-Parkinsonism. And so you get movement disruptions, and a lot of people call this the Thorazine shuffle. That is, people tend to shuffle very slowly and very, very significant disruptions in movement. So those are the extrapyramidal symptoms. Tardive dyskinesia is another very significant side effect. It's much more puzzling and potentially serious. These are involuntary hyperkinetic movements. They often involve the face, tongue, trunk, and limbs. And this is sometimes irreversible, and that's really important to understand how this functions. So, the limbic system, another one of our important brain systems we've talked about, which is involved in regulation of emotional expression and connections to frontal cortex, where emotion and cognition are integrated. Remember we talked about the amygdala, the hippocampus, as part of the limbic system. The amygdala is, of course, involved in emotional expression. The hippocampus is involved in memory and cognition. Connections to frontal cortex between the limbic system are oftentimes disrupted, and this you can end up with dysregulation of emotion and cognition. The phenothiazines reduce the intensity of delusions and hallucinations by affecting the limbic symptoms, and thus tend to affect positive symptoms. That is, it reduces psychosis through its effect in the limbic system. So these drugs do function, but they do have very significant side effects, which is the next thing I want to talk about, when we're talking about phenothiazines, is their side effects and toxicity. Important to understand that managing side effects is key to success in treatment with these particular drugs. We're going to talk about later generation antipsychotics that also have significant side effect problems, and so understand, even with the newer drugs, we have to think about managing those side effects, because patients won't take the drugs if the side effects are too severe, and then they're not getting treated. So we have to balance between the potency of the drugs and the side effects. And this depends on symptomology and treatment goals. And so there's no one answer for for all patients, that is. Each patient has to be treated individually, and you have to be very careful when working with these drugs in a patient to monitor side effects, talk to the patient, make sure that they are comfortable taking the drug, and if not, maybe try a different drug with a different side effect. None of these are going to be without side effects. It's a balance between the symptoms and side effects to try to get a functioning human at the end of the day. And so I think it's a really important thing to keep in mind. So this is the phenothiazines. Again, these are older level drugs, but they are used, and it's important to understand where we come from to understand how we ended up where we are today. There are alternative first-generation antipsychotics. One of the ones that was in use significantly when I worked in mental health was haloperidol or Haldol. Has similar efficacy to the phenothiazines. It's well absorbed orally, has moderately slow metabolism and excretion. You get stable blood levels for up to 3 days after the drug is discontinued. So if a patient goes off their meds, they're not going to be symptomatic for a couple of days, so there's an opportunity to intervene and get them back on their meds and get them stabilized. This drug functions by complete blockade of D2 receptors. Now, obviously, that's going to cause significant side effects because of that complete blockade of D2 receptors. So the side effects are comparable to the phenothiazines. So while this is probably a better drug for treating the symptoms, you get the same level of side effects as you did with the previous drugs. There are two other first-generation antipsychotics I want to talk about. Melendone, which is Moban, similar efficacy to phenothiazines, structurally similar to serotonin, but functions as a dopamine blockade. Has comparable efficacy to traditional antipsychotics. Isn't used much, but it is available. And then L'Occitane is similar to atypical antipsychotics structurally. That is the newer drugs we're going to talk about, but functions more like the phenothiazine. So you get similar side effects, similar drug profiles. So these are a little bit of a preview of some of the newer drugs. Next, we're going to talk about the second generation, or what we call atypical antipsychotics.